Thanks very much for having me on. I'll try to keep my comments brief. So my name is John Lynch. I'm a professor of medicine in the Division of Allergy and Infectious Diseases at the University of Washington School of Medicine, and I am an infectious disease clinician at Harborview Medical Center here in downtown Seattle. From the hospital perspective, we're really preparing for what is, I think, pre-pandemic, a typical respiratory virus season. We saw lots of different things happen during the COVID pandemic. With really COVID predominating most of the conversations, and a lot of other viruses that we are typically used to seeing sort of either disappearing for a period of time or occurring at fairly low levels. I think what we're looking at now is probably the first true post-pandemic season of respiratory viruses. So we're already dealt with COVID over the summer, and like last year, we fully expect to see things like RSV, respiratory syncytial virus. We're going to be seeing other human viruses like metapneumovirus, other coronaviruses that cause colds, as well as probably a typical influenza season. I say probably because every influenza season is fairly unique, and we're dealing with a new landscape of viruses that some of my colleagues can speak about in terms of those different influenza variants that are out there. So the other thing we're dealing with in healthcare, and hospitals specifically, is a different landscape as well. We have not returned to a full pre-pandemic sort of landscape within our healthcare institutions. At my facility and many other UW medicine facilities and other healthcare facilities in Western Washington, our numbers remain high, and the complexity of patients in that post-pandemic period remains elevated. So as we look at potentially seeing a lot more folks who are being exposed, infected, potentially need to be seen in clinics, emergency departments, and hospitalized in our hospitals, it is a different environment that we're moving into that we're still figuring out how to adjust to and respond to. Last thing I'll say is, we have a lot more tools now as to understanding what we're going to be moving into. I would say one part is we have a lot more data now around what's circulating in terms of respiratory viruses. In terms of COVID, maybe not as good as we once had, but still more data than we've had in the past. Thanks to colleagues, some of whom are sitting at this table, our colleagues in public health and others, we have a lot more respiratory virus dashboards. So I can look at the UW's virology lab and look at a whole host of different viruses and where they are trending right now. And through public health, look at things like ED discharge diagnoses for influenza, RSV, and COVID-19. If we go to the pre-pandemic period, I had very little insight or visuals into those trends, and that allows us to understand the trajectory of many of these viruses, which drive a lot of clinic visits, emergency department visits, and hospitalizations, and unfortunately deaths in our patient populations. So that's a great thing. The second other big part of this, which again, Dr. Chu can speak to, is the vaccine landscape. We have influenza vaccines, continue to be one of the most, if not the most important tool we have to protect our population against influenza. We have the updated COVID-19 vaccines. We have RSV vaccines, which became available last year for particularly pregnant people and older adults. And we also have some monoclonals for very young neonates who are at higher risk for RSV. So we look at what's coming. What I'm really looking at is a full-on respiratory virus season like we've used to have pre-pandemic with the addition of COVID, but greater understanding of what the trajectories are around viruses in terms of their sort of epidemiological trends, and also some more tools, and probably more tools than we've had in the past that we can deploy to mitigate some of those potentially negative impacts. And with that, I'll turn it over to Dr. Greninger.
Thanks, Dr. Lynch. My name is Dr. Alex Greninger. I'm a professor in the Department of Laboratory Medicine and Pathology here at the University of Washington Medical Center. I'm going to talk a little bit about some of those tools that we have here in the Department of Laboratory Medicine, focusing on testing as well as the viruses themselves that are spreading right now. So from a testing angle, that is one of the things that came out of the pandemic, is a real significant growth in the amount of data and testing that is still being done. Right now, you can go and ask for 4 free coronavirus tests from the federal government. That's something you can do right now that can help you get prepared for the respiratory season as it comes. There are also at-home antigen tests that cover flu and COVID that are FDA authorized and available for purchase. So that's another thing that's happened in really the last year and a half for new testing for things that you can do at home to have flu and COVID testing. From the testing standpoint, here at the University of Washington Medical Center, we're basically executing the same sort of typical respiratory season playbook. We have PCR tests for individuals coming to urgent care and to the EDs throughout the UW medicine system, and many other hospitals as well will have access to that rapid PCR testing at the door of the hospital, as well as being able to test people who are inpatient for a broad variety of viruses. And that's something we can basically just expect to have going forward. Most of those tests at the ED side are going to test for SARS-CoV-2, flu, and RSV because those are the major viruses they're spreading during the respiratory season. However, there are other testing. We can also test for other viruses in other populations that have more significant disease or immunocompromised, obviously for pediatrics. And all that data, as John said, is available at the University of Washington Virology Lab Respiratory Virus Dashboard. And that's a publicly available resource that has data for Seattle Children's as well as UW Medicine testing. In terms of the viruses themselves that are spreading, let's first start with COVID. Right now, you're seeing mostly a bunch of this KP 3.1.1. It's always hard to remember all the different variants and keeping everything straight up, but that's the predominant strain that's spreading. That is what is close to what the vaccines, most of the COVID viruses have been spreading for the last several months have been sort of in this JN1 KP variant sort of antigenic group. There is a recombinant that people are writing about right now that's XEC that people are excited about because it's showing us a little bit of a growth. It's still early days for it in terms of the numbers that we're seeing, but that is overall not largely different than the other viruses in the sense that it's a subtle change, exactly what we expect from viral evolution, a subtle change that leads to a diminution in protection in terms of from prior immunity as the virus just makes little changes that sort of chip away at prior immunity, but it's not like a major shift by any means. It's still in the sort of the same antigenic space. For flu, I think the main thing, we're executing this, the tests that detect the spreading H3N2 and H1N1 viruses. I also think it's really important given that we have so many H5N1 viruses spreading in cows and in avian species, that this is a really important point, existing tests for influenza A can detect H5N1. Now it'll detect it as flu A, right? So it's not going to necessarily type it and say it's H5. That typing has to be done at a public health lab. But that at least we won't, it's not like COVID, it's not like the 2020, early 2020 where we didn't have a test for it at all. This at least we can pick it up as a flu A, and so testing there will cover that, and then we can figure out if it doesn't type as H3 or H1, then we can find out the information. And I think with that, I'll turn it over to Helen and talk about the vaccines and whatever else.
So my name is Dr. Helen Chu. I'm professor of medicine and epidemiology in the School of Medicine and Public Health. I am a physician scientist. I study vaccines, and I sit on the advisory committee for immunization practices for the CDC, which makes the vaccine recommendations for use in the United States. I'm going to provide an update on the vaccine landscape for the fall. So overall, as John and Alex have said, we've had quite a number of new vaccines that have been approved in the last 2 to 3 years, both for SARS-CoV-2 and also for RSV. I'm going to first start with influenza, though. So the thing that happened during the pandemic with influenza is that one of the influenza viruses, in influenza B, no longer circulated in the community. And we think that because of the pandemic mitigation measures, that virus disappeared. And so as a result of that, as of this year, the new flu vaccine that you get only contains 3 components. It contains protection against H3N2, H1N1, and one of the influenza Bs. And this is different from prior years where we had a flu vaccine that contained all 4 components. But we no longer need to be protecting people against that 4th component because it's no longer circulating in the community after the COVID-19 pandemic. The other major update in flu vaccines this year is around self-administration of flu mist. So prior to this, you would come to the doctor's office and you would get your flu vaccine either by injection or by a spray up your nose. And as of this year, the FDA has approved self-administration of flu mist at home. So you can get a prescription from your doctor to pick up flu mist from the pharmacy and then give it to yourself or to your children at home. And it really will help, I think, significantly, especially when families are very busy during flu season, to be able to self-administer flu mist at home. And it can really, I think, increase uptake, particularly in young kids. The major updates in RSV, so lots and lots of exciting things have happened in RSV, respiratory syncytial virus. So this is a virus that is the #1 cause of pneumonia and hospitalization for infants in the United States. In the last 1 year, we have had licensure of 3 vaccines for adults over age 60, as well as 1 vaccine for pregnant persons, and a monoclonal antibody to be given at birth to all infants. And so last year, what we saw was that there weren't enough doses of nursivimab, which is the monoclonal antibody, for every infant who needed to receive it in the U.S. They were able to give high numbers of doses in Europe, and what we found was that if you give doses to infants when they are born, you can prevent 70 to 80% of hospitalizations due to RSV in these countries. And we think that's what it's going to look like in the U.S. this year, that we're going to have much higher uptake of this monoclonal antibody, and that we're going to see a dramatic reduction in the number of babies being hospitalized for RSV. And remember, RSV is the #1 cause of infant hospitalization in the U.S., and it's what causes surges in pediatric hospitals worldwide. And so what will happen, I think, is a really different season than what we've seen in the past, where suddenly the hospitals are not filled to capacity and won't have to go on divert during RSV season, because babies will be receiving this monoclonal antibody at birth and won't end up having to be hospitalized with RSV infections. So it's a remarkable achievement. The other thing that we know now is that the RSV vaccine that you give to older adults, it seems to last at least 2 years and possibly 3 years. So if you got it last year, then you don't need to get another dose this year. And potentially you may not need to get another dose for yet another year. Pregnant persons should get an RSV vaccine during their pregnancy, or they should get that monoclonal antibody for their babies at birth. I think the last point I'll touch on is co-administration, so getting all your vaccines together. There's a lot of data to show that you can get those vaccines together. It's probably better to get them in separate arms because it generates a stronger immune response if you get one in your right arm and one in your left arm. But it is fine to get them together. You get an adequate immune response and you're protected against the viruses if you get the 2 vaccines together.
Thank you, everybody. We're going to open it up now for questions.
I'm a little confused about if you've already had the shot, you're good for a year or maybe 2. Are you suggesting that you don't have to get a COVID shot every year if you're older? Or?
No, this is for the RSV vaccine.
Okay.
So the RSV vaccine is only recommended right now for adults age 60 plus with an underlying medical condition, or all adults age 75 plus, or pregnant persons to protect their baby. The COVID vaccine is recommended for every single person and should be given probably at least every year because protection really only lasts for 4 to 6 months. And for certain immunocompromised people and older adults, you should probably get it more frequently than that.
I'm wondering if you all could talk a little bit about if flu RSV season has in fact started since the school year began, maybe a month or so ago. What have numbers looked like? Is your life sequencing that right now?
Can you repeat the question?
Yeah, so the question is basically, has flu and RSV season begun? There's a few trace positives. It's like we're at that liminal stage right now where if I said no, I'd be wrong because there's actual detections. But if I said yes, I would be underselling December and January, which are, the major portions of the season. So it's just beginning. This is why we're having this conversation right now. It's a great time to get vaccinated for all the vaccines that Dr. Chu talked about. Does that answer the question more or less?
Can I just add to that too? I think Public Health Seattle King County like some other counties in Washington State, has developed a respiratory virus dashboard that, like the dashboard that Alex mentioned, is publicly available, and actually I think pretty easy for folks to understand, even if they don't do this work all the time. So you can get a look at how people are being seen in the emergency departments, specifically for RSV, COVID, and influenza. So you can kind of get a sense of where we all are right now. And it also has some sort of trigger thresholds for actions that places like hospitals may take around masking and similar. So I think a really nice thing that we have now are data that the public, everybody can look at and sort of see where we all are, rather than that information being sort of sequestered with a small group of experts.
I would say that the caveat to all of that is that a lot of people are testing for COVID at home, and so that information is not well captured in these dashboards. But in terms of COVID, we had a late summer surge, and those numbers are actually starting to come down. The RSV numbers are right around 1% right now based on Seattle Children's data, and we have not seen very much influenza. So for RSV and flu, we're at low levels. For SARS-CoV-2, we're actually coming down from a peak. Yeah, so the numbers of people who've gotten booster vaccines have remained very, very low, something around the 10 to 15% range, and it's higher in older adults, and those are the ones who certainly need it more because they're higher risk for hospitalization. But overall, the numbers remain incredibly low. I think people still have a lot of COVID fatigue, and they are not getting their vaccines.
Is that for Seattle area, like county?
I don't know that we have numbers for this season yet.
Oh.
We have the numbers from this past season. The cumulative numbers are around, I think, 10 to 20%. It's quite low. So.
And that's definitely at least continued the past couple of weeks as the boosters come out.
I don't know that we know. I think it's too early because the boosters just came out. So.
How worried should people be about getting a disease? Should people continue to wear masks in high dense areas, high dense crowds?
I mean, I'll say personally, I think that masking is a great tool. That's one of the other things we learned from the pandemic. It's a fantastic tool to use depending on your personal circumstance, but it's something that you can control that can make a difference. But John is the real expert here.
No, I don't know about that, but I mean, I think Alex really summed it up. So masks work. It is very clear. And the more of us that wear masks, particularly in indoor crowded settings with poor ventilation, the better they work. Sort of like vaccines. The more of us that get vaccinated, the better they work. And so, especially as we move into respiratory virus season, if you are a person who is at higher risk, right, the same type of person who may need an RSV vaccine, right, that's a great person to really focus on that because it is under your control. But all of us play a role in protecting those individuals as well, and so wearing masks in indoor settings. And so just to, one place where I know it's going to happen was in UW Medicine, in all of our healthcare facilities. When we hit a certain threshold in RSV or influenza or COVID-19 as we move into the fall, we will move back to required masking in patient care settings because we know those are really important tools to protect patients in our spaces. And we've done that in partnership with our public health colleagues, including Public Health South King County and other healthcare facilities and organizations in Western Washington. Same as we did last year. We know it worked and it was a great tool.
I was going to say that if you were to pick the place where you're going to mask, it would be places that are indoor crowded settings with poor ventilation. So if you're planning on going to a concert, a large indoor party, riding public transportation, crowded public transportation, those are the places to put on your mask because those are places where the viruses can spread and you can become infected. And other places, I think, places where you have good ventilation, outdoor spaces, certainly those aren't places that you need to mask, certainly right now. So
So my question is to you three. What do you say to people that are hesitant to get their vaccines, whether it's COVID or the flu or RSV? What would you say to those folks?
So So the way we approach those conversations is really to try to meet the patients where they're at, to understand what it is about the vaccines that make them hesitant. People are hesitant for a lot of reasons, and they sit on different places on the spectrum of hesitancy. So some people are very much a hard no. And so for those people, we're not going to be able to convince them to get a vaccine. Some people want to get the vaccine, but they don't want to get it right now because they're afraid of the side effects. And we can talk about that and think about strategies to mitigate those side effects, taking some medicine to help with the fever or the sore throat or the sore arm afterwards. And then there are other people who don't want to get all the vaccines at once. And so those people, you can space the vaccines out. So it really is just getting an understanding of what it is that's keeping people from getting the vaccines. Sometimes it's something so simple as I don't have a place to go to get them. And that is also something we can help work out.
Just really quickly, could you all talk a little bit about, we know there's been a rise in whooping cough in the state this year, and what does that look like? Are there any updates on that front?
Yeah, so this is an issue that I think people have started to talk about, but we actually don't have great data. So whooping cough is caused by bacteria, and we actually don't have good tracking mechanisms for this. What we really see is hospitalizations to some extent, but then that data is usually kind of far out from the actual case itself because it has to do with like billing and discharge diagnoses. So I would say right now, nationally, we don't know what the situation is like discreetly, and I don't know what it looks like in Western Washington, sort of the way that Helen was speaking about some other things. What we do know is during the pandemic, we saw very little whooping cough. Like we saw influenza go away during some of those middle years. And what we definitely know over the last year is that whooping cough numbers have returned to their pre-pandemic numbers. So, you know, that's like 10,000 plus cases per year. And so we have another area where we have vaccines available. And we know that these vaccines are very effective in protecting those at highest risk from whooping cough, namely neonates, right, children, which we know hospitalizations are very dangerous. And if you haven't seen a child or a neonate with whooping cough, it's quite terrible. And so everything we can do around getting our vaccines into the right folks on that schedule is really important. Because, like I said before, what I think we're going to be moving into, and I think we got a sense of a little bit last year, but I think we're going to see more this year, is it's like going to be a normal respiratory virus season. I don't know what you guys think, plus COVID, right? And in a population where vaccination rates might be lower than we've seen pre-pandemic.
I was going to make the point that the COVID vaccine hesitancy has really bled over into routine childhood vaccines in a way that was unanticipated. And so a lot of children are under-vaccinated, particularly by the time they enter kindergarten. So we should expect to see outbreaks of measles, of whooping cough, of all of these other things in populations where we had not seen it in the past, because the vaccine rates in young children have gone down significantly since prior to the pandemic. There was an outbreak of whooping cough many years ago, about a decade ago here in Washington State, in adolescents, and we should also probably expect to see something like that. There is now a recommendation for a booster dose for your pertussis vaccine in adolescents to prevent this waning immunity that you get from getting your childhood vaccines. So you should get your booster if you're due, and you should make sure that your kids are up to date on their vaccines. And if you're pregnant, you should get a Tdap during pregnancy, because that antibody passes to your baby and protects the baby during that most vulnerable period of time.
Alex, are you seeing similarly the lab, what you see in the lab? How does it impact the lab rates?
Sorry, help me understand the question.
Well, I'm trying to, we're seeing less people vaccinated. Has our numbers gone down in what we're testing because of less
Well,
people getting sick?
honestly, from the diagnostic standpoint, the major change here is increasing automation and availability of testing for multiple things. So there's a great paper that was published a few months ago showing that if you go back 10 years, the amount of RSV testing that's being done is like 19 times higher in pediatric, mostly in children's hospitals in that population, which is great because it means that we have better data, which is sort of what Dr. Lynch has been saying. So there is that aspect too, that the underlying all of this is potentially sometimes more testing, more data. But that doesn't change anything that what Dr. Chu and Dr. Lynch are saying in terms of the issues with vaccine hesitancy, the lower uptake rates among kids going to school. That's where we get the most bang for our buck and the most prevention. We're here on the backside in the diagnostic lab. You don't want to talk to us.
The level of COVID testing data is a little bit less than it once was, even though that's still higher than it was pre-pandemic, of course. Can you elaborate on that a little bit? What are some of the challenges there, and what has been scaled back?
Yeah. I mean, there's a number of challenges. I mean, I think the amount of testing that was done during the COVID pandemic was a lot. We had, community test sites. There was a response to an acute pandemic, very, very appropriate too. Now we have at-home testing. That data often doesn't get reported. That's great for people to be able to test in sort of other situations in a very cost-effective, sort of cheap test manner. But you can use that for other sort of sometimes not medical associated questions for individuals. So that's really great to have that piece of data, but it doesn't often get carried forward, reported to dashboards. It certainly doesn't come to us. Those samples may not get sequenced. They're not going to get reported to public health, and so you just kind of lose. That's just sort of an area that you don't see. We have wastewater. We don't do it, but public health does a lot of wastewater testing, so we can sort of track levels and sort of understand what's spreading on a sort of composite sample in the community. But from a testing angle right now, it's really, it's sort of like more like sort of what Dr. Lynch said in terms of a pre-pandemic, like if you are coming to an urgent care center, if you're urgent care, or you're coming to the hospital, going to your outpatient physician, we can get testing actually relatively quickly, same day, and get results back for those individuals. But it's more of a individual sort of medical sort of program there.
Sorry if you've already talked about this. Could you talk a little bit about whooping cough? I know that it's been... Oh, no, you haven't you?
Go ahead, here.
We're going to wrap it up with your question, and then maybe you might stay for about 5 minutes.
Sure. So hopefully I say the same thing I just said since you have me on camera. So we actually don't have a lot of data around whooping cough. What we definitely know, and as Dr. Chu can speak to, we've had outbreaks in the past. During the pandemic, we saw very little, like we saw with other respiratory viruses that weren't COVID, like influenza went down. We didn't see many whooping cough cases. And as far as what's going on right now, we actually don't have much data for a lot of the reasons that Alex mentioned. We just, how do we collect that data? Who gets tested? What we definitely know is over the last year, whooping cough levels have gone back up to the same levels they were pre-pandemic. So I think the numbers I remember seeing are something around 10,000 cases, of hospitalizations per year in at-risk, I think mostly children, neonates. And that's very similar. It's almost the exact same as we saw pre-pandemic. So as we've moved into the post-pandemic period and you see decrease in masking, I'm going to turn over to Dr. Chu here to talk about the impact of vaccination coverage. We're starting to see sort of that return to pre-pandemic levels of pertussis. I do want to just, again, come back to, because we talked about masking earlier, is that, we went all these years, we got rid of one influenza virus, right? We didn't see pertussis. We didn't see a lot of respiratory viruses because of the stuff we were doing around masking and distancing and ventilation and all these other things. So I just want to, again, vaccines work, masks work, staying home when you're sick works, right? The things we do in hospitals to protect patients and coworkers work. We have a lot of tools now that I don't think we talked about in a way that we do now, like that we probably had to some extent before the pandemic, didn't recognize how important they were. So I'm going to turn over to Helen to talk about the vaccine impact.
So I think specifically around the whooping cough issue. So what we know is that after the COVID-19 pandemic, childhood vaccination rates went down significantly for all pathogens. And so one of the reasons why you get your childhood vaccines is to prevent against measles, against pertussis, against all of these things that cause you and those around you to be sick. And until those rates come back up, we're probably going to see outbreaks of vaccine-preventable diseases, particularly in places like schools. And so the point here is that you should get your Tdap booster if you're due, because that immunity does wane over time, and that will help protect you and those around you. And you should make sure that your children are vaccinated, and especially during pregnancy, because infants are at the highest risk for severe pertussis. You should be getting your Tdap vaccine during pregnancy so that your antibody transfers and protects the baby for the first several months after birth.
We're going to start doing some vaccinations now, and then if you guys have additional questions, you guys can probably keep it for another 15 minutes. Is that
Sure.
okay?
Yeah, do it real subtle if you can.
Oh, I'm sure they'll be happy to.
Sarah, if you need names, you want to give the names afterwards. This is Sarah, vaccinator. She's a nurse, Sarah Berg. And then we have, go by Maggie or Margaret? Maggie McCartney, who is 13? Yes.
So Margaret, is this your first COVID shot, or you had some more? How many have you had?
I'm not sure.
Okay, it's hard to keep track at this point. There you go.
What school do you go to?
Einstein. Middle school.
Einstein. Where is that again? Is that in
Shoreline.
Oh, okay. Other shots so far this school year. Which ones?
The flu shot.
Catriona. 15. We go to the same school. No.
Shorewood.
Sherwood.
So I am the manager of employee health services at Harborview, and then before that, I managed the mass vaccine sites at Harborview.
Oh wow. That must have been quite the job.
It was. It was a fantastic job.
You say employee resources?
Employee health center.
Oh, health.
Or health clinic, sorry. Employee health clinic at Harborview.
And these are all COVID shots, correct?
They are, yeah. They're Spikevax or Moderna, whichever you prefer.
Okay.
But yeah, they're all COVID-19 shots.
Gotcha.
Yes. Your life has involved around vaccines for like 4 years.
Mm-hmm.
Gotta have all the techniques, right?
I know. I'm gonna have to put a video on your TV for the next flu.
Mm-hmm.
And have our lives.
That too. That would be a good one. I'm sure people would enjoy watching that. Oh, she's so good, guys. She's so good.
Wow.
So easy.
No tears.
Thank you, Sarah.
3 for 3.
Yeah.
Thank you so much, Sarah.
This is my 1K arm right here.
Yes, it is.
We can zoom in on how to finish.
What
I'm in the